All right, we're going to talk about a few topics relating to obstetrics in pre-hospital and retrieval medicine. It's probably fair to say that as a group of doctors and paramedics, mostly trained in critical care, these cases make us all pretty nervous. I've done several years of obstetrics and they still make me nervous. So hopefully we can have a talk about some of these topics. I'm hoping I can simplify some of the concepts just so that in future jobs you feel a little bit more prepared to cope, I guess, more than anything. A few cases, so have a think about what you might do, what your concerns would be, and how you might make preparations and cope with any problems that could occur in transit. So here's one, 8 o'clock at night, P1 rotary wing of a 19-year-old lady who's in her first pregnancy, whose term in spontaneous labour. Now I'll just show you a couple of maps. This is a Palm Island job, which is about a 20-minute flight from Townsville. But then think about some other jobs. So think about a 2-hour fixed ring retrieval of a woman with severe pre-eclampsia. Think about a preterm labour transfer that's complicated by chorioamnionitis or a womb infection because the membranes have been ruptured. There's so many different obstetric cases that I'm sure everyone's come across, and have a think about throughout the talk and after the talk how you might better prioritise your dealing and prep plans for in-flight emergencies, and how you can simplify management algorithms to get the most bang for buck out of your treatment in flight or at these facilities. A few basic points about the assessment of pregnant women. In terms of history, it's always important just to have a look at their antenatal history, both from this and other pregnancies. It's typically all in their handheld book. Their general medical background that we're all used to, exploring their current problem, whether that be the onset of labour, a rupture of membranes, vaginal bleeding, infection, or hypertensive complications. And then just generically on history, we usually screen for obstetric problems such as the things we've talked about: headaches, bleeding, fluid loss, baby movements. In terms of exam, we know how to take vital signs. The only things that can be a bit trickier for the non-obstetrically trained are just doing an abdominal exam. The key points are to have a feel and time the contractions to get an idea of how many are happening within a 10-minute period and how long are they lasting for. We also typically assess them for how firm the uterus is, but that's a bit subjective, and if it's your first time, you're probably going to struggle with that a little bit. Lie and presentation mean which way is the baby. Is it up and down or side to side? If it's up and down, which is most common, lie. Is it cephalic, meaning head first, or breech, meaning bum or legs first, depending on the subtype? When we talk about engagement on the abdominal exam, let's say we've got a cephalic or head first presentation. It means how much of the head is now down in the pelvis. And again, this is an assessment that you might struggle with. So I guess if you feel the abdomen and you can feel the head wobbling around above the pelvic brim, that means this head is not engaged. And if this is a woman having some early contractions, then really the risk of in-flight delivery is going to be very small. Other things are important. Fetal heart rate, I think as a standard of care, that's a very easy intervention. Don't forget you can use bedside ultrasound for this using either Doppler or M mode. 110 to 160 is the normal fetal heart rate after viability, and it's typically a little bit faster in preterm and extreme preterm. So I'm talking about 24 to 26 weeks. A CTG is a topic in its own. These women will often have a CTG, and you can usually, at the facility you're picking a woman up from, get a bit of an interpretation of that, and it probably isn't going to change your management en route anyway. In terms of other examination features that you might use in a pregnant woman, obviously a vaginal examination or a speculum is something that everyone's had some training in, even if they've not used it a lot since medical school. A neuro exam, if there's a concern for pre-eclampsia. Congenital heart disease or peripartum cardiomyopathy can happen in pregnancy, and then sources of sepsis if that's relevant to the presentation. They're just a few ideas anyway. Labour's worth talking about briefly, just in case people aren't confident with at least the terminology. There are 3 stages of labour in a basic sense. So first stage is referred to as the stage of pains. So this is when the labour's progressing just with contractions. The second stage is referred to as the pushing stage, and the third stage is the placenta. So pains, pushing, placenta, 1, 2, 3. In first stage, the latent phase is the first 4 to 6 centimeters. And the reason it's called latent phase is the ability to predict a woman's progress through that is sort of not able to be done. It can last a few hours to a couple of days. And this is typically where the stories of women's labours lasting several days comes from if they've had a prolonged latent phase. Once women reach active phase, which is defined traditionally as 4 centimetres, but there's, particularly in the first time woman, starting to be a thought that 6 centimetres is a better threshold, it becomes more predictable what their progress through labour is going to be. Now, just to give you guys some ideas, in active phase of first stage of labour, so after 4 to 6 centimetres, a woman in her first baby is commonly going to progress at 1 to 2 centimetres per hour. And if a woman's had more than one baby, then it's typically a bit faster than this. It can be considered normal or acceptable progress to be 0.5 centimetre per hour in a first-time mother. In terms of second stage, so how long it takes once fully dilated to deliver the baby, and this can be up to 2 hours in a first-time mum. So labour's often a bit of a longer game than we're used to with our critical care patients in the pre-hospital and retrieval environment. But again, women don't read textbooks, so it can also happen quite precipitously. Now we'll talk about decision to transport, really just relevant to the first case that we presented. It's complex. We've got the opportunity to talk to coordinators and obstetricians. It really depends on a lot of factors, weather, the status of the baby, antenatal risk, current progress and current stage of labour, flight time, where you're at versus where you're going. And there really isn't a lot of evidence to guide these decisions clearly. So I guess most importantly, involve others in the decision. It probably goes without saying that when we're transporting women in labour, the goal is for them to reach the tertiary hospital and have the baby in the birth suite, not just after they go through the door, but once they've been admitted to the birth suite. If not that, it's best to have the baby in the facility they were in pre-transport. And lastly, really not having the baby in the aircraft is ideal. Birth in aerial transit is pretty rare. It's hard to get an accurate incidence because of how rare it is, but it's less than 1%. And there's been some data sets come out of the US where they transport by rotary and fixed wing women over 6 to 7 centimetres dilated, and even in those cases they did not have births in aerial transit. So it's challenging the decision making. It's scary thinking that you could have a birth in aerial transit. It is pretty rare. If you're transporting a woman in labour, obviously thinking about what is going to happen if this woman has the baby is going to be at the forefront of your mind. And so preparing for that rare possibility is something that's worth doing with your flight nurse, flight paramedic, rest of your aircrew. And I think this is an important time to think about if you're in a 139 or a 412 or you're in a fixed wing, whether that be the 200 or the 350 with RFDS, they're all a little bit different. How are you going to configure your cabin for those individual aircraft? And it might be a little bit different. The next thing to think about is what maternity equipment do you carry? Now, this isn't something that's standardised with life flight. Individual bases have their own packs made up. But think about what items you'd want immediately available. There's a whole heap of things we carry and a whole heap of things we can do, but which pieces of equipment are going to be the most valuable to you? Because particularly in a rotary wing aircraft, there really is a need to, in flight, have equipment as restrained as reasonably possible. So it's not necessarily practical to have a whole heap of equipment set up in preparation for what is a reasonably infrequent complication. And have a think about, well, what am I going to do if this woman has a baby? What am I going to do if she starts to bleed excessively and has a postpartum hemorrhage? what am I going to do if she delivers the head but the shoulders are stuck? And how am I going to approach assessing and managing the baby? Now, I've got some tips for preparation for these jobs, and that is because that initial case from Palm Island actually ended up as 10 minutes into flight, a vaginal delivery at 9 o'clock at night in the back of a 139. And these are some things that I did and things that I've reflected on and thought would be the simplest approach to preparing for an in-flight birth. Now, in the rotary wing aircraft, loading the woman up so that instead of being at the airway end, you're at the other end was helpful. In a fixed wing job, particularly with RFDS, there's usually a stretcher on the port or left-hand side of the plane that ends at the doorway. And I think having the woman on that stretcher is just going to give you more room with another bed off to your right to deal with the baby if needed. In terms of equipment and drugs, I think, to be honest with you, just having some Syntocinon, plenty of that drawn up, is useful. Most women in labour are given intramuscular Syntocinon for active management of third stage, which is preventing excessive postpartum hemorrhage. But that's because women in labour are typically low risk and don't have cannulas. So there's actually no reason why you can't give 5 to 10 units IV for prevention of postpartum hemorrhage. And there's been some RCT evidence to suggest that's more efficacious than IM anyway. And that gives you the ability to have intermittent bolusing of Syntocinon in the setting of postpartum hemorrhage, still in the one syringe that you've drawn up. A delivery pack's pretty standard. That's a couple of kidney dishes, 2 clamps for the umbilical cord and a pair of scissors, as well as some towels is helpful. And then in terms of a neonatal rescue device, I think that just a simple bag valve mask with a PEEP valve is more than enough to have as a piece of equipment easily available for these jobs. There's probably no questioning that for example, the Neopuff is a more effective provider of positive pressure ventilation in a newborn, but the reality is it's a flow-driven piece of equipment, meaning you need oxygen flow, you need some experience with it, and really it's starting to take up a lot of space for what is pretty unlikely to happen. So I think a neonatal BVM that you can actually have work effectively without even an oxygen connection is going to allow you to start early room air positive pressure ventilation. And we know that less than 1% of newborns need any more than that. It's probably worth having a chat with whoever you're transporting the patient with just about some of those things we talked about. I've got a quick video here on vaginal birth. If you look down and you see a woman starting to crown, usually we get them to slow down at this point, to breathe a little bit more like they're blowing out a candle, just to facilitate a slower stretching of the perineum. But at this point, the head delivers, and then without any interference, it will rotate. And this is just to allow the shoulders to come out of the birth canal. Now, at this point, all you need to do is support the head, and just with some traction down towards the bottom, deliver the anterior shoulder like that. You can loop your hands under the shoulders in the axilla that you've seen and lift the baby up without dropping it. It's probably the most basic approach to a vaginal birth I can offer you. In terms of delivering the placenta and cutting the cord, there's a couple of things. First of all, there's no rush to do this. If mum and baby are well, there's no need to there's no need to deliver the placenta unless there's significant bleeding, which doesn't occur commonly and typically doesn't occur until later on, like 30 to 60 minutes. It really doesn't need to be done. In terms of cutting the cord, it's fine to do it early. Sitting in the back of an aircraft isn't the time for worrying about how long to let the cord pulsate for, but leaving it pretty long is helpful because it just is more likely to give you 1 or 2 goes at establishing umbilical venous catheterization. In terms of when it's fine to deliver the placenta, if you're on a longer retrieval or you then arrive at the receiving facility, or if you're delivering a baby pre-transport, we usually look for signs of placental separation to occur before we start controlled cord traction. and they are typically a rush of blood and the cord lengthening. The fundus rising is a bit subjective and is often difficult if you've not done it before. And my only tip is, once the cord is cut, if you place a clamp at the level of the introitus or just below, you can actually see that clamp descend as that cord lengthens. And that's typically a good indicator that it's time to deliver the placenta. And in terms of how you do it, there's some pictures here. So the left hand's just guarding the fundus from causing a uterine inversion. So you're just putting some pressure on the fundus and trying to prevent it from coming down with the placenta. And then you just gently, with your right hand, putting some traction on those sponge forceps to bring the placenta down. Now the direction in this case is down like the baby's been delivered, so down towards the mother's bottom, posteriorly. And then as you deliver the placenta itself, it's often good to put it between two hands, as you can see there, and just rotate it so that the trailing membranes become somewhat braided, and it just increases their strength and means they're less likely to tear and be retained, which is just predisposed to some bleeding and infection. I thought we'd talk briefly about some complications of delivery and pregnancy, just again to try and give everyone a little bit of confidence that they may or may not have had before the talk. So what is shoulder dystocia is important to understand. It is a bony entrapment of a shoulder, usually the anterior shoulder, behind the pubic symphysis. And you'll know you've got a shoulder dystocia if the head delivers and the shoulders don't follow, just with simple traction like we've discussed in that video. So here's a picture here. You can see the anterior shoulder is stuck here behind the pubic symphysis. Now, the only thing to remember is you can actually have the posterior shoulder stuck behind the sacrum, although that's less common, but it can occur. And whilst there can be an entire discussion around stretching of the brachial plexus and other complications, the reality is, particularly in our setting, a prolonged head-to-body interval is highly linked to birth asphyxia. Now, there's a few reasons why babies can become hypoxic. The pathophysiology doesn't matter terribly, but a couple of factors include early placental separation, cord compression, as well as venous congestion from around the neck, with subsequent reduction in venous drainage from the brain. In terms of managing shoulder dystocia, it's important to have an idea what to do and why. There are more complicated algorithms that I'll show you shortly, but just the basic principles that will get you through are to call for help, which is a bit silly in this setting, I guess. Maybe just tell your mate. And this is a time to think about the fact that you might be about to need to do a neonatal resuscitation, so just making sure that bag valve mask is available. It's important you lie the woman flat, and that corrects or reduces the lumbar lordosis, which is more likely to create space for this bony impaction. And the next thing is, which improves that even more, is the legs up position. You can put some pressure suprapubically, just up here, to try and push this shoulder under. And then the other thing you can do is you can roll the woman over onto all fours. Now, this is obviously something you'll need to do carefully in the aircraft and would involve removing patient restraints, so letting the aircrew know about that. The other trick you can do is actually just try to deliver the posterior shoulder. So instead of taking the baby's head and gently putting some traction down posteriorly towards the mother's bottom, you can actually put traction anteriorly. And if that posterior shoulder, which you can see just here, delivers, all of a sudden there's a much smaller diameter that needs to get behind the pubic symphysis, and the baby typically delivers well. So you can look at this at your own leisure. This is the helper mnemonic for shoulder dystocia. It's just important to realise and have a think about, before this happens to you, what can I do in the aircraft and how will I do it? And just understand why those manoeuvres can be helpful. So I think the key ones really are just lying flat, legs up, maybe suprapubic pressure, and then either delivering the posterior shoulder, which I would try before moving the patient in an aircraft. I did a bit of a literature review on birth and aerial transit after my fun night in Palm. And actually the only article mentioning a birth and aerial transit, unfortunately, was a breech delivery in a larger Sea King helicopter in Europe. So that would have been a difficult day out. But it's really, I guess, historically not done commonly anymore, with the exception of second twins. And I guess the history is back in 2000 they found, or at least they thought from a randomised control trial, that it was associated with worse perinatal outcomes. And the problem with that is that whilst there were some methodological issues with that study, it meant everyone stopped doing vaginal breech births, and now there's a real lack of experience in how to do them well. The issue with a breech birth that you need to understand is that in a normal delivery, the cervix will dilate 10 centimetres or dilate completely to facilitate the passage of the largest part of the baby, which is the head. The body doesn't need that degree of cervical dilatation. So if you have a breech presentation that starts to deliver before there's complete cervical dilatation, then the head can become entrapped, leading again to rapid fetal hypoxia. Now, when I was taught to do vaginal breech births by an 80-year-old obstetrician in Townsville, he told me to sit in the corner and sit on my hands, and if you could, stand mum up. Now, maybe this will help you in a remote facility, probably not in flight, but the idea is the babies will often deliver themselves, particularly with the assistance of gravity, and that once you place your hands on the baby, it actually causes an extensor response, which worsens all the presenting diameters to the maternal pelvis and means that you will then have to take over the mechanisms of labour for that breech baby. So if you take nothing else out of breech vaginal birth, if you can stand them up, and we're talking about that for an intrafacility transfer, if you're in a clinic or small hospital, then do that. Otherwise, sit on your hands and let it happen by itself. It's called a breech extraction if it's not delivering and you need to put your hands on. And we won't go through the manoeuvres for that, but there's some resources where you can actually look at that stuff if you're interested later. Uterine inversion is something that happens occasionally. It's pretty much as a result of excessive traction on the umbilical cord in the setting of placental delivery, and it is the reason we look for signs of placental separation before attempting controlled cord traction. I've thought about this a little bit. If it occurs, it's usually heralded by profound pain and then the development of shock, and it's actually multifactorial. So as the uterus inverts, it causes quite a significant vagal response, leading to a worsening hemodynamics, but also it can be associated with significant hemorrhage. So the treatment really is to replace the fundus and then perform bimanual compression. But it is very painful, and you may need to provide significant analgesia and or sedation to facilitate this, particularly in the environment that we work in. So this is, again, something to have a think about before it ever happens to you, just to have a think about how you might deal with it. Here's a picture of replacing a uterine fundus. It's often not as easy as that. It can require a laparotomy, but it absolutely should be every attempt made particularly if there's severe pain and hemodynamic disturbance. In some cases, you may need uterine tocolysis. Terbutaline is a great tocolytic, really easily given. The dose is really easy to calculate and remember. GTN can be given, and it can even be given sublingually. So just, again, have a think about what your go-to tocolytic might be. In these cases, you don't remove the placenta once you've replaced the fundus. And it's not even done in the birth suite when they arrive in hospital. It's done in the operating theatre. It can lead to a recurrence of the uterine inversion, or if you do it when the uterus is inverted and sitting in front of you, then it can lead to life-threatening hemorrhage. All right, postpartum hemorrhage. This is a pretty common complication, and it's quite a scary one if you've ever seen it. You know, the term uterus can have a blood flow up to 800 mils per minute, and the setting of uterine atony, where there's just frank bleeding, you know, that's really rapid hemorrhage. In terms of a definition, over half a litre of blood loss after a vaginal birth is considered a PPH. Women bleed a lot after a baby, and it can be normal. And certainly the first few times you see a delivery, I remember being pretty concerned about a woman who had normal blood loss at the time of birth. It can be quite impressive. It's important to have a bit of an idea about the causes, although in a pre-hospital environment or retrieval environment, it's going to be less relevant and more likely to have just a very standardized approach. Uterine atony is the number one cause. The reason is as the maternal spiral arteries and arterioles traverse the uterine wall to interface with the placenta, they provide the 800 mils per minute at term that we've discussed. The idea of uterine contraction is that when the placenta separates and is delivered and the uterus contracts, all those spiral arterioles are then kinked off and that bleeding is stopped. But if that uterus remains relaxed and all those vessels have their ends exposed, then bleeding can continue to be brisk. Other things that can cause bleeding is genital tract trauma, whether that be a vaginal, a perineal, or a cervical laceration, which may be amendable to either direct pressure but more commonly a hemostatic suture, retained placenta, or coagulopathy. And the mnemonic for PPH is the 4 T's: tone, trauma, tissue, thrombin. In terms of managing in the ED, if you're doing a interfacility transport or managing it en route if you're unlucky enough, just have a think about the T's, but really rub the fundus and call for help in terms of the coordinator and letting your aircrew know. You may need to resuscitate them with products, give some drugs for uterine tone, which we'll go through in a moment, and really bimanual compression should be done reasonably early. And I certainly think once you've had 500 to 1,000 mils of brisk blood loss in the back of the aircraft particularly, or in these smaller clinics where definitive management is quite remote, then early source control in the form of bimanual compression, I think is the right thing to do. I mean, obviously, it's highly invasive and highly uncomfortable, but it's also quite effective. Here's a picture of bimanual compression, and yep, it is, as I said, both very invasive and very uncomfortable, but in the setting of life-threatening bleeding, I think it's a really important skill. The best way to describe how it's done is to imagine configuring your hand like you're about to put it into a Pringles jar. So with your fingertips all together, you put your hand in and once your hand is in, make a fist in the anterior fornix, as you can see, and then with your other hand, bring the uterus down onto your fist and squeeze firmly. In terms of drugs for PPH, we carry these in the standard LRM drug pack. And the two most commonly used ones are ergometrin and syntocinon, and there's some doses there. I wanted to put up the syntocinon infusion rate because it's commonly used as a treatment of postpartum hemorrhage, particularly in obstetric units where they're comfortable with the dosing and used to it. Just remember that if you have ongoing atonic uterus with ongoing bleeding, that by hanging an infusion of 40 units over 4 hours, you're really not addressing the problem. You're really the goal of the infusion is to prevent the uterus relaxing once you have gained control. And if you look at 40 units over 4 hours, that really is only 1 unit every 6 minutes. And whilst that's an excellent prophylactic dose, it's often not an excellent therapeutic dose. Misoprostol can be used. Some services, particularly when they're dedicated maternal services, carry prostaglandin F2 alpha, but it's, again, just things to be aware of. Some rural hospitals will have these, so they can be taken or administered prior to departure if you think that's useful or that's the advice you're getting over the phone. Pre-eclampsia is one we see a bit with intrafacility transfers particularly. It's a poorly understood condition in terms of why it happens, but it's a disorder of placental function, and particularly it's of vascular origin. It really only happens over 20 weeks, although it can happen a bit earlier in molar pregnancies. And the best way to think about the diagnosis is that it's high blood pressure plus any end organ dysfunction, and we'll go through those. So the blood pressure threshold is 140/90, and it's either of those elevated. Typically, they're measured twice to find a high reading, but it's high blood pressure plus any of the following. So any kidney involvement, whether it be significant proteinuria is defined there, or acute kidney injury. Neurological involvement, so headaches, visual changes, hyperreflexia. Clonus is a really good predictor of impending seizures. Hyperreflexia can happen in a lot of pregnant women, but particularly clonus is worrisome. And seizures, being the manifestation of eclampsia, obviously meet the diagnostic criteria. Just to go back quickly to neurological findings, a good tip I had from an obstetrician when I was working as a registrar was that you don't need a reflex hammer in obstetrics. If you have a woman with hyperreflexia that you can elicit on simple percussion associated with clonus, then that's worrisome enough. You don't need a neurologist's technique and an excellent tendon hammer to try and elicit the reflexes that are of significance. Hepatic manifestations such as either elevated transaminases all the way along the spectrum to a subcapsular hematoma and or liver rupture all can occur in preeclampsia, and like any of these end organ manifestations, high blood pressure plus hepatic involvement equals preeclampsia. The hematological system is important, so hemolysis can occur, as can low platelets. There is a syndrome known as hemolysis, elevated liver enzymes, and low platelets, or HELP syndrome, which is a phenotype of severe preeclampsia. And one of the biggest killers in preeclampsia is actually pulmonary edema. All right, so just briefly around the management of preeclampsia. Just so you've got a good understanding, the cure really is delivery. It can occur in the postpartum woman, but typically it's diagnosed or begins either antenatally or during labour. And really the decision to deliver, whilst not one that we make in pre-hospital and retrieval medicine, really is just a balance of how sick's mum and how young's baby. If they're 38 weeks, they get delivered. If they're 24 weeks, maybe you sit on mum a little bit longer. In terms of the decision for blood pressure lowering, over 160, over 100, you're going to be thinking about blood pressure lowering, and it's considered severe hypertension and needing immediate management if it's over 170, 110. Just to remember, the definition of high blood pressure, so 140/90, is actually the therapeutic endpoint for blood pressure lowering. And so that just makes it a bit easy to remember in this topic. The thought is that the uteroplacental unit has had a long time to become used to high blood pressure, and like the concept in the reduction of blood pressure in some neurological conditions such as stroke, the idea is not to return it to normal. Seizure prophylaxis is done in the form of magnesium sulfate for women with severe preeclampsia. Now, it's important to remember that, like many of our interventions, it's not like every single woman we give magnesium sulfate to has their seizure prevented. The number needed to treat is actually 90. The only reason I bring that up is we often feel a little bit overwhelmed when these complications develop. It's an important part and a standardised part of preeclampsia management, but if you've got a couple of competing tasks, it may be fine to leave it to a little bit down the line. In terms of eclampsia, again, the cure is delivery, and it can happen in a woman who didn't have preeclampsia at the time of her birth, but that'd be pretty unlucky, especially in our setting. In terms of the seizures, they're typically generalised tonic-clonic seizures that are reasonably brief and self-terminate. If they're focal, if they're prolonged, it's an indication that maybe something else is going on. Now, magnesium sulfate again is the centre of treatment. The dose is 4 grams over half an hour, then 1 gram an hour. You can give another 2 grams if they have another seizure. But my thoughts around eclampsia really is, if it's not following the described brief, generalised, self-resolving tonic-clonic seizure, then I'll give magnesium sulfate and then essentially progress down a status epilepticus algorithm. That's not necessarily generalised accepted practice, but that's how I have simplified my approach. As one of the last things, I thought we'd talk about maternal advanced life support. Now, in terms of changing our approach to advanced life support in pregnancy, the important things to do are manual left uterine displacement, and this is better than left lateral tilt. Establish advanced life support and establish the shockable or non-shockable rhythm pathway, and then an early resuscitative hysterotomy. In terms of what the published guidelines for this are, and when you look at the literature here, there is, I think, some controversy, but the accepted guidelines are that over 20 weeks or a uterus at the umbilicus is an indication to perform a resuscitative hysterotomy in the setting of cardiac arrest. Beyond that, drug dosing, effectiveness of drugs, site of compressions, site of other interventions, indications for defibrillation and joules are all the same. So simply, adaptations of advanced life support in pregnancy are manual left uterine displacement and early resuscitative hysterotomy once resuscitation has been established. There's an old saying of start a resuscitative hysterotomy by 4 minutes and have the baby out by 5 minutes. This is a good memory aid. It is difficult to achieve though. And if you look at the survival data, whilst it's difficult and not of high quality due to the infrequent nature of this as an intervention, there really is a linear relationship with time to delivery and outcome. There isn't a big change at 5 minutes. The 50% injury-free threshold is around 25 minutes for mum and baby. So there is really a role for this further out from the onset of arrest than we often think. And this probably reflects low flow states, some women getting high-quality compression and left uterine displacement. But that's the information we have. Something I've always wanted to know is how far into a cardiac arrest could I have a maternal or neonatal survivor? Now, there's no doubt this procedure as a resuscitative hysterotomy is done as a maternal intervention, but we shouldn't forget that there is another person and that this awful outcome, this awful event might be made slightly better with a neonatal survival. So it's important not to disregard the role in terms of neonatal rescue completely. So it's very hard to say how far into a cardiac arrest is this helpful, but what you can say is there's case reports of a mum surviving 37 minutes after onset of cardiac arrest and a baby surviving nearly an hour. The numbers I have in brackets as these are babies that have been followed up to 2 for 45 minutes and 4 years old for 30 minutes that have a normal neurological outcome or no neurological deficits of significance when their mum has had cardiac arrest for 45 minutes and 30 minutes. So I guess the point is this can be useful deep into a resuscitation. I'm going to talk lastly about how to do a resuscitative hysterotomy. I'll be honest, I've never done one. I've done many cesarean sections, never done a resuscitative hysterotomy, but I think it's useful just to look at the anatomy. So the anatomy, if you look at this cut section here, is not particularly scary. There is skin, there is subcutaneous tissue, there is a muscular layer, and at this point you're essentially at the uterus. Most of the intra-abdominal organs are displaced superiorly and posteriorly by the gravid uterus, with the exception of the bladder, which can be injured with a incision that's done low down on the maternal abdomen, but this does not matter. This is not of consequence if you're doing a resuscitative hysterotomy. The goal is to remove the baby. Now, in terms of what you need, it depends on where you're at. This is going to be an ideal list, and I'm writing this up because this might be the only talk you have on this for your in-hospital practice. But it really would be useful to have 2 scalpels. The reason I say 2 scalpels is particularly disposable scalpels if used on on a person when there's not adequate traction and counter traction on the skin can become blunt quickly. So I think having 2 is a good idea. Scissors or shears as well are something that you're going to need, and an extra set of hands. Now, beyond that, you don't need anything else. Some things for managing contamination might be helpful, and your air crew might appreciate that. But again, it's not a necessity. Clamps from the delivery pack can be helpful for managing any ongoing bleeding from the uterus, but really it becomes a secondary priority after re-establishment of ALS, with the view to whether or not ROSC has occurred, leading to post-ROSC care, etc. So really, you need 1, ideally 2 scalpels, a set of shears, and another set of hands. Anything above that is a bonus. In terms of the surgical steps, continue advanced life support and manual left uterine displacement. It's okay to cease them for the beginnings of the resuscitative hysterotomy, because it is a difficult procedure. You're unlikely to have done it before. You're likely to be very stressed, and you're likely to need a little bit of help with it. So a big scalpel, big cut. Vertical midline incision from the top of the uterus that you can feel to, let's say, 5 centimeters above the pubic symphysis. Cut in that plane or in that orientation through the tissue planes down to the uterus. At this point, you need to incise the uterus, and you can use the shears or a scalpel to extend that incision. When we're doing a typical cesarean section, we'll often bluntly extend that with our fingers, sometimes sharply extend that with scissors. But in this setting, if you just put one hand in and guard the baby, I think the best way to extend the uterine incision is going to be with the trauma shears. And again, this is in a vertical orientation, and you can just do this the length of the baby. Pull the baby out, cut and clamp the cord long, and this is for the same reason that we've spoken about earlier, about the ability to put an umbilical venous catheter in, and then back to the mother. Now, if you're lucky enough to have an in-hospital setting with a lot of staff around, you can remove the placenta and think about some local hemostasis. But really, in the pre-hospital and retrieval environment, it's back to work on mum, because you have a very limited team. But if you do get ROSC, remember there is an opportunity for significant bleeding both from the surgical site, as well as you've essentially created all the conditions that lead to postpartum hemorrhage. So ongoing bleeding is likely to be a big issue. So that's all I had to say about obstetrics in pre-hospital and retrieval medicine. I know that was a lot to go through. I hope in some ways it's been useful. I hope you've all had a chance to have a laugh at me about my birth in aerial transit. I can promise you it was reasonably stressful. But all the best to everyone, and I'll see you guys at work.